most people don't think nightmares are changeable, and so they don't report them to their healthcare provider. 85% of U.S. adults have had a nightmare in the last year, and so we work to really carefully craft a new dream that the person would like to have. Over time, it gives the brain a new path to go to when you're dreaming at night.
That is so cool and obviously effective too.
If we can teach you to become aware of your dreams while you're dreaming, and then we can teach you how to make some changes in your dreams while you're dreaming, you can change the outcome and not have such distressing or upsetting.
Dream within a dream.
You can change the dream within the dream.
Hello and welcome to Sleep is My Waking Passion, the podcast where we get real about sleep and how it shapes your life. I'm Dr. Alison Kole, a triple-boarded pulmonary critical care and sleep medicine physician who's learned to thrive despite having chronic insomnia. And now I'm here to help you do the same.
Hello and welcome back to another episode of Sleep is My Waking Passion. You know who I am. Today we're going to get to it. So I am joined by Dr. Courtney Worley. She has many accolades, including PhD, amongst many other certifications, and she's board certified in clinical psychology, and she's a diplomate of behavioral sleep medicine. So again, one of these really expert behavioral sleep medicine people I've had on the show before, who specializes in evidence-based treatments for insomnia, nightmares, which is going to be the focus of today's discussion, so don't tune away. You're going to want to learn about this, and PTSD. She co-authored the Nightmare and Sleep Disorder Toolkit, a workbook to help you get some rest using imagery rehearsal therapy and other evidence-based approaches. And this is based on the American Academy of Sleep Medicine's leading recommended treatment for nightmare disorder. So this is really an expert who is teaching you really how to help yourself. And then we're going to talk a little bit more about when you need to actually go and seek out a real professional to help you with this. She has led national training initiatives in the U.S. Department of Veterans Affairs for trauma therapies. As somebody who trained at the VA, this really, it tickles me and it holds a special place in my heart because your job is not easy with what veterans have lived through often. And she now trains clinicians in the United States and internationally on how to use cognitive behavioral therapies for sleep and PTSD while maintaining an active clinical practice focused on trauma and sleep disorders. Welcome. It is such a pleasure to meet someone who's as experienced as you, especially with the nuance of nightmares.
Thank you. I'm so happy to be here today and to get to talk about nightmares. It's something that, as you mentioned, not many people specialize in. So I'm trying to change that. I want to make sure more people have access to treatment, whether that's healthcare providers or people who are struggling with nightmares.
And believe me, this is not something, as a medical physician, I do try to help people through issues related to nightmares or figure out if there is another sleep disorder that's contributing to what's going on with them. But it's otherwise the peek under the hood about what I really tell them to do. I mean, I'm talking to you today specifically with a specific patient in mind who I hopefully will be seeing shortly for an appointment. And as I mentioned to you, I have every intention of discussing your book with said patient because I think it's really, really important. So if any of the listeners who are sticking around to hear this have literally searched, why do I keep having nightmares? Or how do I stop bad dreams? How would you explain what a nightmare disorder is and when nightmares become a real sleep problem rather than the occasional bad dream, right? I think all of us have had the occasional bad dream, but what sort of distinguishes it?
Absolutely. It's common among sleep disorders that most people have kind of experienced a symptom here or there, right? I think about everybody's had a bad night of sleep, but when does that become insomnia disorder? Well, about 85% of U.S. adults have had a nightmare in the last year, but certainly not that many have a nightmare disorder. So when we think about moving into this diagnostically, we really think about some key factors that are shared across the different diagnostic symptoms that we use, but some of my colleagues in this area have come up with a great acronym that I like called DARC. So D-A-R-C. D is disturbing or dysphoric dreams. A is they cause awakenings. R is there's recalled content. And C is about clinical distress or impairment. And so those things are really key when we think about nightmare disorder, that most people think about having the disturbing dreams, but is it causing an awakening? Are you recalling the content? That often helps us distinguish between nightmares and other sleep disorders that may have awakenings without recalled content? And then is it really starting to impact the person in their day-to-day life? Because we know sleep is a 24-hour process, right? Everything that happens during the day impacts sleep, and our sleep impacts what happens the next day.
What are some of the more common reasons why people have frequent nightmares? What do we need to be thinking about in them?
I think the go-to for most people when they think about nightmares, they think about trauma. And trauma-related nightmares are incredibly common. But nightmares really are both a transdiagnostic symptom and something that just occurs on its own. We see nightmares showing up in other psychiatric conditions like depression and anxiety. We see it showing up in other sleep disorders like narcolepsy and REM sleep behavior disorder. And it can show up due to some medical concerns and medications and substances, in particular those that impact sleep and REM sleep can sometimes create more opportunities for nightmares. And so I really think about nightmares as a transdiagnostic symptom. It happens across a lot of other conditions, and sometimes nothing else is going on. Nightmares because of times of high stress and disrupted sleep. And for some people, that kind of fades in and out over time. For other people, it's more persistent.
You were specifically mentioning, hey, do you kind of remember what's going on in terms of what triggered it as being one of the diagnostic criteria? So we have different stages of sleep. For those of us listening, we have non-rapid eye movement sleep and we have rapid eye movement sleep. And you can kind of have bad things happen in both. Or people will say, what I've had are some patients who, what I describe as being a non-REM parasomnia, where they may be screaming. It sounds kind of, but for me, what I distinguish there is I go, they don't really remember what happened in that dream versus a lot of people who have it in rapid eye movement sleep do. Can you kind of take us through sort of what the differences are between a nightmare, which I associate with REM sleep, and please correct me if nightmares also occur in non-REM versus a non-REM parasomnia, because I think I look at them as being two different things. I actually don't know if that's a correct thought or not, to be honest.
It's a mostly correct thought. So most nightmares are going to come out of REM sleep, but not all. And in patients with PTSD, about 40% will have nightmares outside of REM sleep. So the timing of the nightmares, right? We typically think about if somebody's reporting content or distress in the first half of the night, we tend to lean towards a non-REM parasomnia, but that's not always the case. It could be that additional content, additional assessment is needed to kind of figure that out. If they're not having content, then we might think about we're pretty solidly in the non-REM parasomnia, like a sleep terror. If we're talking about clearly in the second half of the night, we're more often thinking about the REM-related nightmares, because REM is a time where our body and our brain are working really hard on fear extinction and kind of processing memories and emotions. And so that's the most common time for people to have nightmares, but it's not exclusively there.
What do we do about these nightmares? Talk me through some of the tools that you have found to help treat people with nightmares. And it sounds like, and also too, please enlighten me. I don't know what the data is for whether or not a behavioral therapy approach, for example, is better than more of a pharmacotherapy approach, and whether or not we have data on that. I'm curious.
We do. We have clinical practice guidelines. We have a position paper from the American Academy of Sleep Medicine that actually lists behavioral approaches and imagery rehearsal therapy specifically as the frontline treatment for nightmares. It has more empirical support than other treatments like medications. There is absolutely a role for medications, but a lot of people don't get offered this first line treatment of behavioral interventions for nightmares. And so that's one of the things that is a part of my mission is to provide people with opportunities to learn about these treatments that work usually pretty briefly. 4 to 6 sessions is kind of the typical for most patients. So it's a brief episode of care for most people, and we see pretty lasting results. We work with, the sleep stages. We work with the sleep cycle, improving sleep quality and continuity. We work on reducing hyperarousal. We work on the nightmare content. And so it's a really active treatment where you meet with a behavioral provider about once a week for an hour over the course of a month or a month and a half. And then between sessions, you're using skills in your day-to-day life to make some of those changes that carry over into sleep and improve sleep quality, continuity, and reduce nightmares over time.
Can you describe to us what imagery rehearsal therapy is?
Absolutely. Imagery rehearsal therapy is the frontline treatment. It's one of 3 that usually gets recommended for nightmare treatment. But it's just the one that has the most research. And we're working to do the research on the others too. It's just an area where we need to catch up in our science. But imagery rehearsal therapy takes the idea that nightmares become scripts and habits over time. When people have the same nightmare over and over again, their brain is pulling the same imagery that matches the distress. Oftentimes people are going to bed anxious for a lot of different reasons, but including the fear of having another nightmare. And so we work with this idea that nightmares get consolidated into scripts by creating new scripts. And so we work to really carefully craft a new dream that the person would like to have with lots of detail, sensory detail, sight, sound, smells, thoughts, and feelings. And we assign a pretty specific practice schedule so that the person walks through that dream in their imagination while they're awake. And we find that over time, it gives the brain a new path to go to when you're dreaming at night. So instead of having this typical well-worn nightmare path that it's had, we can kind of create this new path for it to take, and people are able to have dreams that are not distressing, not impairing, and are not creating these awakenings at night.
So you are, in fact, using our brain's ability to have neuroplasticity to kind of rewire how we're thinking about this. That is so cool and obviously effective too.
Yeah. One of the biggest challenges, I think, in getting people to start imagery rehearsal therapy is kind of the buy-in for it, because it sounds a little bit too good to be true sometimes, especially when I work with people who've had nightmares for years and even decades. And they'll kind of be shocked that really I can what it's going to take years for this to change, or I need something more powerful than just kind of creating a new script and thinking through it and changing some of my behaviors around sleep. But really, we see those effects take effect really, really quickly, especially when people put in the work. So it's one of those things that works if you work it. So more practice, more consistency really leads to changes pretty quickly.
And really, this applies to folks who have insomnia that may not necessarily have something that's trauma-related or nightmares per se, just difficulty with sleeping, right? That's, I think, the crux of, in part of what we're doing with cognitive behavioral therapy is starting to rewire a relationship with that bed. And it kind of applies even to, if we're getting more woo-woo or metaphysical here, just in terms of our approach to life, the more flexible we can be with our thinking, the more we can allow opportunity to happen, because we're saying, no, I'm not going to just always have a negative thought pattern. I'm going to see what happens when I stop and smell the roses a little bit. So I think there's so much application to this it just goes to show that our brains are a lot more plastic and moldable than we've been led to believe, even as we get to be adults.
Even as we get to be adults, even as we get to be older adults, because sometimes people will say, I've had this nightmare for lots and lots of years. It just can't change. In fact, I hear a lot of those kinds of myths around nightmares that I'm just the kind of person that has nightmares, or, this is not something that is going to change for me, or I'm just going to have to live with this. In fact, most people don't think nightmares are changeable, and so they don't report them to their healthcare provider. They don't think it's something that can get treated. And so we're really working to try to change that on both fronts by providing education to say, hey, nightmares are treatable, but also to talk with healthcare providers and encourage them to ask, how are you sleeping? Are you dreaming? What's the content of those dreams like, to really assess for nightmares, because we know that it's not uncommon. 2 to 5% of the population would meet criteria for a nightmare disorder based on the current epidemiological data. If we go into more nuanced populations, it can be even higher. So much more common in women. It can happen at different stages of life. Around perimenopause and menopause, we'll see increases in nightmares sometimes. In people who've been exposed to trauma, of course, higher rates of nightmares. And so this idea that psychological flexibility is important. One, we're capable of change. And then two, working with the neuroplasticity of the brain to create some of those changes really pays off in dividends for our sleep quality, which then impacts the quality of our life.
You alluded to a couple of other treatment options that maybe are, not as well vetted, but still options. I want to hear about these. What else should we be thinking of?
Well, I'll start with one that is very well vetted and is a surprise for people. Cognitive behavioral therapy for insomnia can be used as a nightmare treatment. So cognitive behavioral therapy for insomnia works to really improve sleep quality and sleep continuity. And if we're able to improve sleep and people have less awakenings, less anxiety around going to sleep or how well they're going to sleep, it can reduce nightmare content or nightmare awakenings. Other two treatments that we think about and we talk about in the Nightmare and Sleep Disorder Toolkit are variations on imagery rehearsal therapy. So one is exposure, relaxation, and prescription therapy, which is like imagery rehearsal therapy, but with a little bit extra. And we often use that one for people who have trauma-related nightmares, whether they're true replicative trauma-related nightmares that replay the trauma in some way, or if they're what we call symbolic or intermediate nightmares. And those are ones that have the same themes or the same emotions as nightmares, but it may not be a true director's cut replay. And so it's kind of the sign that the body and the brain still haven't processed all of those memories or those nightmares. And so with those, we use exposure therapy. And this is a place where my colleague, Dr. Nadorf, that I co-wrote the book with, and I have kind of a friendly disagreement. And I think it comes from the different places that we work. And so because I come at this from a lot of years of experience treating PTSD, I think you've got to do the exposure, which means having somebody to write out their target nightmare in a lot of detail. And then we look within that target nightmare for where is the place where it gets intense or distressing or disturbing, and we change it from that point forward. And so we kind of use the stem of the start of the nightmare and then make the changes, as opposed to just writing a nightmare about some unrelated topic from scratch. So ERRT, exposure, relaxation, and prescription therapy, is like IRT, but with some extra components, namely exposure. And then the other treatment that we talk about is lucid dreaming therapy. And so lucidity is when we are aware of dreaming while we're dreaming. Some people have natural capacity for this, and everybody else can be taught. And so the idea is if we can teach you to become aware of your dreams while you're dreaming, and then we can teach you how to make some changes in your dreams while you're dreaming, you can change the outcome and not have such distressing or
change a dream within a dream.
You can change the dream within the dream. Is that cool?
Wow, that is so cool.
Absolutely. And it's been really powerful to see that work with some of my patients. And so being able to change it so then whatever happens, they can make changes, because some people will say, I'm the same nightmare all the time. I have kind of variations or themes. And so it might be hard to just target one with a prescription. So instead, we might load up the toolkit with some ways to change it as it's happened, or pack some things to bring into our dream to help us.
So for those of us who are now incredibly intrigued that we could actually maybe fix some of the things, these nightmares that we maybe don't actually even acknowledge because we feel like we just got to live with them. What can they expect from getting the Nightmare and Sleep Disorder Toolkit? And when do you know that it's time to really take it to the next level, maybe have that one-on-one consult? I think, how do we make that link, and what can we expect people will get out of the hard work that you've done to publish this?
With the Nightmare and Sleep Disorder Toolkit, we take all of the skills that we use in clinical practice and lay them out in a way that creates tasks and skills for the individual to use. Or I've had a lot of therapists tell me that they pick it up and use it with their patients. And then some healthcare providers just have it in their office or available through their practice, or, give their patient a link or a handout so that they can use it as well while they're treating something else. Or some people don't want to see a therapist or a healthcare provider for nightmares. So this may be a good tool, or they may not have access. There aren't enough of us.
That's true. You guys are like unicorns. Let's just be clear, 7,500. And from the statistics that you gave me, we're looking, I don't know, on the order of maybe 10 million people. And that's probably an underestimation that have issues with nightmares.
And you're talking about behavioral sleep medicine providers, which not all of them will treat
7,500 sleep providers, even less of you. I think there's like 750 of you. I should thank you for correcting me on that.
Yeah. Well, I was just even going to say that your behavioral sleep medicine provider who typically treats insomnia may not have an opportunity to treat nightmares. They may not have had that training. It's kind of a specialty area. But we're working on that. But a lot of people don't have access. Can't find them. I mean, I see people across 43 states through my upward behavioral health practice. So some people can find me, or they can go on the Society for Behavioral Sleep Medicine website and find some of my colleagues that may be available where they live. But I think in the book, The Nightmare and Sleep Disorder Toolkit, we want to solve this larger public health problem by giving people individualized skills to use. We lay out what all the treatment options are, and then we talk about how to create your own plan to work through if you hit roadblocks, what to do, if you have successes, what to do. We give some example patients that you can kind of follow their stories. So you might find that John or Tony match up with your experience, and you might want to kind of model your treatment after theirs. And we give lots of tools. We also talk about when you might want to see a professional. So some people will have nightmares, awakenings with nightmares that are, clearly recalled content. Some people will talk about having awakenings that feel like nightmares. They may have shortness of breath, a sense of panic, but they don't have recalled content. And so that's when I get concerned about obstructive sleep apnea, which is incredibly common to co-occur between nightmares and obstructive sleep apnea. Behavioral therapy, other than maybe helping you to wear your CPAP a little bit more, is not going to target obstructive sleep apnea, right? That's when we need to coordinate with our colleagues in sleep medicine to treat that medical condition. Yeah, hi. Work with a lot of relationships in our treatment team with sleep medicine colleagues that help us with that side of the house. And then sometimes they send people to us to say, hey, can you help with PAP adherence? But that would be a time. Also, if there are some other symptoms I mentioned, that nightmares can occur within other sleep disorders like narcolepsy or REM sleep behavior disorder. And with those, we would really want somebody to have a full medical evaluation because they would need additional tools. Now, I have a colleague within the Society of Behavioral Sleep Medicine, Dr. Jennifer Munt, who's doing some amazing work with treating nightmares within narcolepsy using imagery rehearsal skills. So it still could be a part of it, but it's a part of a larger treatment package when we're talking about narcolepsy.
Thank you so much for bringing up the fact that there are sleep disorders that are intimately connected. And so I think sometimes maybe it's a human construct of being a human being. We tend to like to just identify and bucket everything. And one of the neatest things that I have learned on this journey in medicine, especially in sleep medicine, is that there are so many overlaps of sleep with every other aspect of our life and even our health and other medical conditions, sleep disorders, and of course, the psychology behind all of it and neurology, that it's really helped to de-silo us. The fact that we can come together and have this discussion. And I'm going to, in full disclosure, Jen Munt, I know you were busy and I pestered you before, but now it is Courtney has brought you up. Spencer Dawson has brought you up. Girl, we got to talk because I definitely want to showcase nightmares in narcolepsy. I think it's such an underrated topic. So I'm making a shameless plug in case she's ever would listen to this episode to see if I can convince her to come on.
She is the person.
Thank you for that.
She's my expert when I have that question.
And she's busy. And it's hard to work with her schedule because what she's doing is so important. But anywho, I digress. I wanted to end this because I know we have limited time and I've got to get you to your next patient, to just say thank you for your time and thank you for helping me sort of create this environment where we can complement each other. This is not an antagonistic relationship. And I think sometimes in medicine, everybody wants to have a certain lane that they stay in. And I'm all about crossing lanes. Like, I'm not going to follow the traffic. I want to zigzag in and out. I want us to all be working together because I think ultimately a team approach is what gets our patients where they need to be. I think in all of medicine, but particularly when it comes to sleep issues.
and their disciplinary care is best.
Where can people find this book?
They can find this book at our publisher website, New Harbinger Press, and there are some additional free tools. We've got a couple of bonus chapters on nightmares in kiddos and nightmares in trauma, and some recordings to help with that hyperarousal that we talked about. So those are free downloadable recordings, whether you buy the book there or not, for breathing retraining, for imagery rehearsal, for lots of tools to kind of help with that hyperarousal. And so I encourage people to go to the website to check that out. But it's also available kind of wherever books are sold. So New Harbinger would be the place to get all the free tools, regardless of where you purchase the book.
Excellent. And so everyone listening, if you go and you're looking at the description, there will also be a whole Substack article on this. I'm going to make sure we have all the links so that we can make sure as many people hear about this important work that you are doing as possible. Thank you again.
You're welcome.
Struggling with sleep? Dr. Kole is here to help. Whether you need a comprehensive sleep coaching program, suspect you have sleep apnea, or simply seeking a second opinion, she's available for consultation in New Jersey, New York, California, and Georgia, with more states coming soon. Schedule your free 10-minute review of services today to find out which visit is right for you at AskTheSleepMD.com and start your journey to better sleep with a trusted sleep expert.
Please be advised that the Sleep is My Waking Passion podcast is for entertainment and educational purposes only. It does not constitute medical advice. Always consult your healthcare provider for personalized guidance. For my full disclaimer, please visit AskTheSleepMD.com. And while you're there, don't forget to sign up for my free newsletter. Sweet dreams and happy listening.